I don't know if any of you guys were at the last Healing Summit when we got to have Kathleen Lisson there. That was just such an absolute joy. And we were lucky to have her there. And we're lucky to have her here this evening. And let me tell you, strap in. This is good. When she says adventure, she means adventure.
Yeah.
Yeah. And Kathleen, do you have anything you want to say before you start, or?
No, so you don't have to furiously have your pencil taking down a whole bunch of notes. I have the PowerPoint. As soon as my my website guy gets back to me, I'm going to put it on my website, so you'll be able to see the PDF of all the slides tonight. So don't be worried about like taking a million pictures and stuff. And then, so I'll try to go through the presentation, and then we can have questions afterwards. Okay, great. So I am going to start presenting. Okay, so we'll talk today about oncology massage after breast reconstruction. My name is Kathleen Helen Lisson. I'm a lymphedema therapist. I'm a board certified massage therapist, S4O preferred practitioner, and a NCTMBA approved continuing education provider. I came to oncology massage like kind of with my hair on fire when I first learned about it when I was in massage school about 9 years ago, because my mother was diagnosed with breast cancer when I was 9 years old. I was just a child. And back in the 80s, it was like radical mastectomy, and the whole 9 yards. You shouldn't lift more than a gallon of milk. You can't exercise. And so these little hands couldn't really help my mom. So when I became an adult and then went to massage school, to understand that not only could my hands help, but reading medicine hands book, that there's so much research behind the positive effect we can have on our clients. I was just really, really excited. I really love that my the lady who taught me oncology massage was very nice to me, because I didn't actually have my California certification yet. I was still in school, but I begged and pleaded to sit in on the lecture because I needed to know as soon as possible all this information. And I understood that I would have to wait and finish massage school before I could actually get my hands on somebody. But she was like, okay, you can sit in on the lecture, because it's just us sitting in a room. So I was just so excited always to learn more information and trying to get as much knowledge to be able to help clients that were like my mother and like my father. So I got to do my hands-on at Morris Cancer Center, which is at the hospital here in San Diego, and do hands-on in the infusion room. And that really helped me in my career, because I believe if you start off with the education of an oncology massage therapist, like regular healthy clients are so nice, aren't they? Like, whew, like clients with no like major issues. It just makes, and you have so many, like I have so many bolsters and pillows and ideas in my office to be able to help all my clients. So what do I want to talk about today? We're going to talk about why people have reconstructive surgery after breast cancer, what's changed over the last 10 years in breast cancer reconstruction surgery. We're going to look at some research together. I'm going to talk to you about what my most common client, that's an oncology with a cancer history client, massage after breast reconstruction surgery involving breast implants. We'll also briefly look at some medications that our clients may be taking to reduce the incidence of capsular contracture, and I'll explain what capsular contracture is. And at the end, I'm going to share some information about breast implant illness that I just want you to keep in the back of your head as one other option of what might be happening with our clients. So let's begin with, why do people get massage after cancer surgery? So kind of do the global, and then I'll go into way more specific about what I do in my office. So this is our first researchers that I'll share, the researchers at MD Anderson Cancer Center. They looked at 473 patients that were referred to integrative oncology, and they found that most of their referrals were stress, relaxation, and pain and anxiety. So that's understanding that most of our clients, that's why they're coming in if they're referred into integrative oncology. And then I want to niche down to what I do. But interestingly, I always love a good symptom assessment scale, because this can like help us in our SOAP notes. So if you want to look at one more symptom assessment scale, the ESAS scale, it helps assess pain, tiredness, nausea, depression, anxiety, drowsiness, appetite, well-being, and shortness of breath. So it's a pretty good quick overview of what some symptoms that our clients can come in with. So why do people have reconstructive surgery after breast cancer? Because you don't necessarily have to have a reconstruction. An absolutely valid option is to have an aesthetic flat closure, and a lot of people are getting aesthetic flat closure, but some people are wanting to reconstruct the breast and the breast mound after they have had surgery to remove the tumor. So the research tells us that many patients are seeking reconstruction because they want to reestablish the breast shape and the volume to limit the adverse biopsychosocial impact of the mastectomy on the patient, restoring the body image, sense of their femininity, and improving their quality of life. So this is the result that I want to see, even like me as a human being. If my client on the table is going through breast reconstruction, these are the reason why she is going through it. We have to understand that there are disparities with breast cancer reconstruction. So depending on whether you're in an urban or a rural place, what part of America you're living at, what are the socioeconomic status of your clients, you may see a wide disparity in how many of your clients with a breast cancer history are coming in with after reconstructive surgery. So it's important to understand this. This is a journal article by researchers from City of Hope, and they looked at the effect of federal mandates. And so this is, if we learned oncology massage a long time ago, before 1998, before this federal mandate that said if you had breast cancer, that your insurance should be covering some of the follow-on surgeries. They said from 1998 to 2015, almost all rates of the autologous, immediate, and delayed breast reconstruction have doubled. So this is the first big thing. If you're doing oncology massage in the late 80s to mid 90s, you're seeing a whole different landscape now, aren't you? But despite the federal mandates like the Women's Health and Cancer Rights Act of 1998, the access and use of care is still unequal in America. So these researchers found disparities in breast reconstruction. If the patients were minorities, if they were public insured or uninsured, they were having lower cases of breast reconstruction. If they were rural, low income, they had poor access to the community hospital, and they were non-English speaking. These people tend to have lower rates of breast reconstruction being offered to them, even if they had the same case as someone who wasn't a minority, who had private insurance, who was living in an urban area, who is high income, had access to hospitals. And it's the access to the breast surgeons and was English speaking. The research has shown that there's a higher incidence of those people getting offered breast reconstruction. So we need to understand this as the foundation of when we're looking at breast reconstruction, understanding that it's not offered equally to all of our patients from an equity standpoint. So what has changed over the last 10 years of breast cancer reconstruction? So if you took all your training 10 years ago and what is happening now versus 10 years ago, again, fantastic research study. I love it when these surgeons go through all their records and share what they've learned with the other surgeons in their journal articles. So over 3,000 mastectomies, the surgeons looked at surgeons from Mass General Hospital, and they found that versus 10 years ago, what they're seeing more now, they're doing less of the skin reducing surgery, and they're finding more nipples they're able to save the nipple. So even for me, even if it's like in the past 8 years, I never used to hear of like people would just not have nipples after their mastectomy. And now we're seeing more where these surgeons are getting better, the surgery is getting better. They're not just focused on like a thin flap, their skin flap vascularity is better. So the quality of skin flaps is getting better. We're seeing more nipples after mastectomy, which blew me away the first time that I really realized that I was seeing that. And it used to be more like a bilateral mastectomy, and now it's unilateral. But interestingly, maybe because of the surgeon that's referring his clients to me, I'm seeing a lot of prophylactic mastectomies. I'm seeing a lot of people now that this wasn't looked at in this research, but in my personal practice, there must be a lot of genetic testing here. And I've been genetically tested twice. And I'm BRCA negative, but my mother had breast cancer. But the people who are testing BRCA positive, the people who are in my office that say like, my sister, my aunt, my mother, my grandmother, like there's just all this cancer in their family, and they're opting to get that prophylactic mastectomy and then the implants and then the fat transfer for their reconstruction. But for as far as this study, they said they're seeing more unilateral surgeries, and then the skin flaps are thicker. And most important, especially over the last couple years, what I've seen, and then it's even coming into cosmetic surgeries now, is the use of acellular dermal matrices, or ADMs, are being inserted into the surgery to control the breast pocket, and they have an effect on capsular contracture as well. So the basic methods for reconstruction. So the lady has had her surgery, the person has had their surgery. What happens in the reconstruction? They can reconstruct from a flap. So you might have heard deep flap or tram flap. And this is, they're taking tissue, skin from the abdomen and the underlying the vessels to keep the skin flap alive, and they're transitioning it into the breast. So you'll see like a scar of a flap on the breast as a flap reconstruction. So it's their own skin that's coming up, or you can have an implant-based reconstruction. So that's an artificial with silicone on the outside, and either there's silicone on the inside or saline on the inside, and implant, a medical device is implanted into them. And then, like they say in the research article, there can be a hybrid reconstruction where they'll use a flap and an implant, or that I get a lot of cases where they use an implant and then they'll do fat transfer with liposuction and fat transfer to the breast. So we can see a flat-based, an implant-based, or like a hybrid-based. So what I would say as far as advice, I've seen deep flaps in the office. I usually see them 2 weeks out. They're usually in the hospital for a couple days because they have to make sure that that flap is alive. So you're not going to see someone in deep flap surgery like 3 days after their surgery. But once a surgeon approves them to have the manual lymphatic drainage, if you know manual lymphatic drainage, I am taking the swelling and I'm pushing it to the axilla, especially if they had prophylactic mastectomies, so there's no lymph nodes involved. And it's because there's a lot of swelling around the donor site. So I'm directing the fluid from the donor site up into the axilla. If there's an implant there, I'm usually seeing them because they're getting an implant and fat transfer. So the liposuction area is what I'm helping with. I'm doing manual lymphatic drainage, like starting 5 days to 2 weeks later, based on when they call me and when they can get an appointment. And I am directing fluid according to their usual watersheds that you would have learned in your MLD class. So like I was almost sharing previously, many clients I see for breast reconstruction after breast cancer here in San Diego have reconstruction involving liposuction and fat transfer to the breast. And I think this is really whether a doctor moves in to your town that knows how to do this procedure and is offering it to them. I remember I was an oncology massage therapist before, and I remember I went to lecture as a lymphedema therapist in the Livestrong program. And I remember the first time I went in there to lecture and someone said, this doctor, he's putting fat into the breast. I've never heard of that before. And then go to now, like I'm seeing all these clients. So I've really been, it's interesting once you get a few years under your belt, you're existing as an oncology massage therapist and seeing these advances happen in real time and helping these clients that maybe you didn't have the education on how to help them when you were in oncology massage class, because that surgery wasn't popular back then. So let's look more deeply into this. So fat is harvested with the same like liposuction cannula as they would use for cosmetic liposuction, but instead of throwing it away, they're saving it, they're processing it, and they're inputting it, they're placing it into the breast tissue. So what I see, this research is giving you a list of where these surgeons are saying you can take it from. I usually see the fat taken from the abdomen, the medial thigh. So if it's a very low BMI client, that just the lady that had cancer that's just skinny, 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 they might not get enough off of the lower abdomen. They might have to go to the inner thigh. And then the flank, that love handle is another good place to between the skin and the major muscle and on the reconstructive breast. So it's mostly like the upper pole and then a little bit the cleavage area. Implant-based reconstruction is the most common method of immediate breast reconstruction. And they looked at over 39,000 immediate breast reconstructions, and they found that the surgeons were using these ADMs in over 55% of cases. It's very interesting because the ADM is not actually approved for this use case. It's like an off-label use, but it is used so profoundly by so many surgeons for so many years. So let's talk about, we're continuing to talk about breast reconstruction with the implant. So if we're going to put an implant in the breast, there's two different, and then there's always three, but there's two main ways you can do it. You can put the implant in front of the pectoralis major muscle underneath the skin, or they can kind of hide that implant and put it under, or like in a hybrid, kind of like in between some fascia. So it's the prepectoral where it's on top of the pectoralis muscle, or the subpectoral. So what we saw for a long time was the implants were going under the pectoralis major. But now surgeons are putting it on top of the pectoralis. Yeah, I think it's just you get either me or my slides, which is a shame. We got through most of the slides. I think the big takeaway I would say is if you're going to help the client and they have the breast implant with the mesh, you want to wait 6 to 8 weeks, because the idea of having a mesh over the implant is that the mesh is going to help form a scaffold for the capsule. So every time we put a medical device in the body, whatever medical device it is, because I have two, every time we put a medical device in the body kind of forms a covering over it of scar tissue. And I like to think of it as an oyster. If you put a grain of sand in an oyster, it kind of covers that, so there's no direct interface with the medical device and the body. So that's the capsule, and the capsule forms, it's natural, it's supposed to be there. Everyone has a capsule. The difficulty with capsular contracture is when something goes wrong and the scar tissue is kind of contracting around the implant and getting too tight or too thick. and or too calcified, and that's called capsular contracture. It's actually the #1 most popular concern that leads people back into having a subsequent surgery. So basically what I do in my practice is I have a surgeon, Dr. Champanaria, that does breast reconstruction surgery with implants, and then he does liposuction on the clients. Most of the liposuction happens in the lower abdomen. I like to joke about, like, there's the fat that no matter what you did, if you hit the gym like 10 days a week, that fat would never be gone. And that's that fat on your body right there is the fat that we want to transfer to the breast, because it's the fat that will live forever. So usually that is like on the lower abdomen. If it's a really skinny, low BMI client, it's on the upper inner thigh. And on that flank, like the love handles. So they'll transfer it to like the upper pole of the breast and a little bit on the cleavage. It's a very tiny, like they almost have to do it droplet by droplet. They can't just squirt a bunch of fat and hope that it lives. So the client will come into my office at about like a week, week and a half, 2 weeks, and they will complain about swelling from the liposuction area. So I even have them, depending on how comfortable or uncomfortable they are. Some clients are just really like, I need to leave, you know, the surgeon told me to leave this bra on all the time. I need to leave my compression bra on. And then I was like, I'm fine. I'm fine with doing that. I can work around the bra, no problem, because I'm not going to try to force someone to go against their surgeon's advice. So I will do menial lymphatic drainage on the areas where they had liposuction. Just like if you take care of clients that have lymphedema, the patient will come in with some kind of compression garment, and then I will put, if they don't already have foam underneath it, I'll put like 1/4 inch or 1/2 inch of the gray foam that we use for lymphedema clients. Sometimes they'll come in with like an ABD pad, and they'll come in with a binder, like a white binder type garment. So if the surgeon wants me to massage the breast implant, if the surgeon is telling the client to massage the breast implant and self-massage, I will do that if the client wants to. And then I have a release form that I have them sign. And some other surgeons are okay with menial lymphatic drainage, like a week or 2 on the breast, on the area of fat graft after the fat grafting. But if the client is not complaining about swelling in that area, I usually leave it alone. If they have that mesh, that dermal matrix, I'll have them wait at least 6 weeks, because the dermal matrix is going to be the place where the body is going to put like the scar tissue that it would put like in a capsule. So what I don't want is to have that mesh that the doctor just specifically tacked around an implant, and then I go in and massage the breast tissue and I displace that mesh before it's done doing its job. So I want to wait 6+ weeks, 6 to 8 weeks before I'm doing any real massage on the lower half of the breast if the person has an ADM or a mesh. I'll also show the client self-massage, self-MLD, and then I use like little silicone cups if they have some fibrosis or some thickened tissue, and I'll show them how to cup by themselves. That really empowers them, and it gives them the tools that they need to take care of themselves in between the massages. If the spouse or partner comes, or child, and they want to massage the client, I will show them how to massage, and I will usually have like, I'll do the MLD, and then I'll have the partner do the massage, and I'll say, what did you feel that was different, you know, and have them kind of verbally guide their partner to say, oh, that was, you know, too deep, or that was too intense, or you're going too light now, so that they can get the partners confident into giving them the massages in between their appointments with me, because like everything, like we're trying to get them self-sufficient in their own care. We need to understand that they're not just coming to us for like I have swelling of my, like it feels tight, it feels heavy. They may also have issues with shoulder range of motion. And always remember the drain scar. If they've had drains, they have the little scar where the drain comes out, and that is often the thing that irritates them the most, is like that drain scar, and whether it was like the scar tissue from under it is touching a nerve, or it's just really sensitive, it's right up against a rib maybe. And I try to tell them, like the surgery took 7 hours and then that incision was closed, but that drain scar, that drain that was open for a week, and it had a tube sticking into you and sticking out of you. And then that kind of lets them know, like, oh, it's not so surprising that it would still be, frustrating to them. I always do neck and back massage, upper back massage on my clients. They're usually sleeping elevated, so I will elevate them on a wedge. And then if you're not used to sleeping elevated, especially if you're a side sleeper and all of a sudden you have to sleep on your back because of this operation, they appreciate the neck and the back massage, and they've been through multiple cancer operations, so they appreciate the neck and back massage. And it's also important to know that they may have a limited range of motion because of radiation. So if they went through radiation, the radiation, even after it's done, it's still making changes in the body for, like the next year or two. So that's why they may say, oh, I haven't had radiation, for 6 months, but all of a sudden I'm feeling I'm curled up, I'm feeling tighter, and just things that we can do to increase their range of motion in the shoulder will really help them. The class that really helped me and informed me was close training. They did a class on breast cancer rehabilitation with Jody Winnicor. I highly recommend taking that class, and you can see how the physical therapists and occupational therapists are helping people in their offices with radiation. And then also to know that after breast cancer surgery, like the client wants this to be their last operation. But so they can be scared that they're not achieving the result that they want with this first fat transfer. And we have to understand that the breast itself is changing over years after the surgery as the radiation and the breast itself changes. So there's opportunities to go in and have a little bit of a touch-up surgery. It doesn't have to be a one and done with the fat transfer and the implant. So if everything turns out fine at their 6-month visit, they like their results cosmetically, then they're fine. They don't have to have another fat transfer. But I always say, if you're noticing like this dimple and this hollowing and this, something's frustrating you about the operation, just understand that this doesn't have to be the last. Like, your surgeon's not going to lose your number and forget your name. Like, you can go back and have a touch-up surgery. Yeah, and then Jen said there's a new level 2 breast rehab course from Close that Jody just released as well. So there's plenty of information there. So I myself have a class. It's breast massage after implant and explant plastic surgery. I dive a little bit deeper into what we've spoken about today, and especially some very interesting results with people that think, surgeons that thought the client had the capsular contracture, but once they put the patient under anesthesia, they found that the pectoralis muscle softened, and they found that it wasn't an issue with the implant. It was an issue with the pectoralis muscle having fibrosis. So some very interesting things that the surgeons are doing with Botox, which I think is fascinating, and the pectoralis muscle. And so that gives us hope as massage therapists that if we are massaging the pectoralis muscle, the shoulder, we can get the client's improvement. And I always ask the question to the clients, like, how is your range of motion? Is it just, can you do everything you need to do? Is it the same from one arm to the other? Is it the same substantially? Are you able to do the same things you were able to do before the surgery, before the cancer? Because a lot of clients will kind of have this silent conversation with themselves that, like, leave well enough alone, like it's good enough, I can just make do and do other things, like I can reach painlessly, but it's not, you know, there's still a little pulling here, and just kind of, it's okay. And I tell them, you don't have to have the impression that just because you're alive, like you should just be grateful to be alive and not be pushing for the best healthcare that you can have, because we can get, if we can get you better, if we can get more range of motion in that shoulder and get more comfort in the upper torso area, that's what you deserve as someone who had this surgery. You don't have to say, you know, so many people have died from breast cancer and I'm alive, so why am I complaining about it? So that is kind of my passion, to help people live their best lives, because after every client that I see that it has a breast cancer history and is out there living their full life inspires me as someone who has breast cancer in my family, that if the breast cancer happens to me, that I can, because of the healthcare system we have now and the benefits, the advances that we have now, like I'm optimistic about everyone's chances for survival after breast cancer and returning to a full life where they can do everything that they want to do with the next 30 or 40 years of their life. And that's kind of what I talk to people about, is you do have a long life ahead of you. So let's not push this stuff aside. Let's get it done correctly now and give you all the strength that you can have so you can go forward and live the life that you deserve. So that is basically my presentation for today. I did want to say a little bit about breast implant illness. If you have a client that does have breast implants and they're talking about how they have fatigue, how they have joint pain, unexplained rashes, if they have all these different constellation symptoms that may also be something that everyone would say, oh, well, you had chemotherapy, oh, you had radiation. Another option for what might have happened to them is something called breast implant illness, which is the body's reaction to the silicone implant being put in the body. And there's plenty of research on this. There's an FDA website with the link that I put when we get to look at the whole presentation on my website in a few days. That link, you'll be able to click and see all the potential symptoms that people can have with breast implant illness. So if you're kind of if you have a client who has a cancer history, who has breast implants, and you feel like you're kind of beating your head against the wall with how am I helping this client? We're just, everything we're doing, nothing's really working. It's worth it to take a look at, could it possibly be breast implant illness? And Robin Tout is one person who's very outspoken about this. She got breast implant illness after she had cancer, breast cancer surgery, and then reconstruction with an implant, and she started getting sick. And she found that it was breast implant illness. The surgical the surgery for that is explant. So they take the implant out and capsule out. It's called explant surgery, and there's more and more surgeons are performing that. And they do find that the symptoms can reduce after you take that offending, if the body is reacting to the implant, and they take the implant out, they can see a reduction in symptoms. They're finding, based on research, that it's better if the implant hasn't been in that long, and they're seeing more breast implant illness in clients that also have like a history or propensity for autoimmune diseases. So it's kind of something to keep in the back of your mind, that this might be the reason why you're really just like knocking your head against the wall trying to help this client, and kind of nothing that we're doing is really giving them an improvement. So thank you very much for letting me talk to you about this exciting topic, even though my computer was not participating with this talk. I will have the slides to you, and they will send you the link to the slides in the email, so you can kind of see all the slides, and you can see the picture of the acellular dermal matrix, which is really what I wanted to show you. But yeah, by the end of the week, hopefully all those slides will be up at KathleenHelenLisson.com. All my other resources are at KathleenHelenLisson.com, including my classes to help people after plastic surgery, including there's a class that shows you how to help people after liposuction, and then one specifically about breast implant and explant surgery. So thank you very much for letting me talk to you today.
Kathleen, thank you so much. And we are the lucky ones. I'm sorry it was such a rough go with everything this evening, but I think we all got a lot of good out of it.
Kathleen, this is Amma. I so appreciated your talk at the last conference. I had 2 clients coming yesterday. Both are older clients that I haven't seen since 2023. Both have had problems with their implants. One of them had some sort of burst with her implants, and I can't remember the location of that implant, but she had a surgery a few months ago and is doing much, much, much better. She had the deep flap, and she said, like, there's still this like necrosis of fat tissue that she had before that she still has that's causing her a lot of emotional pain because this lump in her breast that she can feel. And then the other thing is that she said her belly is really, really, really tight. And they redid the belly button and, you know, just from taking the fat out, I guess. I'm wondering if you can speak to that. And then my other client had her implants under her pectoral muscles, and she's a dancer, and it has caused her lots and lots of pain and discomfort and limited range of motion and can't do push-ups and things because the pectoral's in the wrong place. And she is seriously considering having another reconstruction to get not under the pectoral muscles. So I'm just curious if you have any thoughts about that.
Yeah, I think, and if it started with breast cancer, I'm under the impression that she can have that covered by our insurance. Like she can have it swapped from under the pectoralis muscle to over, which I think is I think a lot of people are doing that. I've seen it there's research article where they're switching it from under to over and seeing improvements on clients, even like cosmetic clients. And I think we don't counsel enough. We don't talk about it in public at all. Like implants, it's like some secret thing that you shouldn't talk about. But if you jam an implant under a pectoralis muscle and then you try to like work out and live your life and do push-ups, you're going to have an animation deformity. Like the pectoralis isn't going to work correctly if there's like a ball underneath it. So I don't blame the pectoralis for that at all. So that's an option for her, especially if she's having a lot of pain. Like, why wait? And it's covered by insurance. Like, why suffer any longer? So I do some for the deep flap. I do. Has she talked to the doctor about just going in and taking the necrotic lump out? If it's really affecting her emotionally, like that should always be an option. Because
that particular client does not have health insurance, and when she did the reconstruction, I don't know why they didn't remove that. I have no idea why they didn't address that, but it's still there, and she does not have health insurance.
Yeah. Do you want to massage it? Do you think it'd get smaller if she massaged it, or does she just need to have health insurance and have it taken out?
I worked with visualization of light, and I came up with a visual of pixelation. So like bringing light in and having this big chunk of hard tissue, like, you know, work its way into smaller and smaller pieces that the body could then, you know, digest or filter out or whatever. And that's kind of the visual we work with. And I did put my hands on, and some with just still holding and a little bit with a little bit of massage movement, but that's where there's a lot of emotional fear and pain. So interestingly, when she did the reconstruction, it moved from closer to her armpit to more center chest. And she goes, yeah, so I mean, it's just a little easier to reach, so it's less hidden. I think that's probably a good thing, but I'm not really sure. Not really sure.
Yeah, I mean, if she's open to some kind of scar massage on it, that might be an option if she's open. But if that's gonna like open a can of worms, sometimes
Yeah.
it's just an incision and excising it, like taking it out.
Yeah, I mean, I did encourage her to like spend some time with some castor oil in the next month or two and see if it makes a difference, because that can't hurt, right? So
And I use like lengthening myofascial strokes from like the mons pubis up to the rib cage to kind of lengthen out the abdomen area. A lot of people feel a tightness in that area just because they're like moving the muscle, and there's a lot of surgery down there. And is she exercising? Is she doing like core rotational movements with exercise?
she actually has been wanting to get back to tennis and has just recently become a tennis coach. So she is getting some core movement that does involve twisting to some degree, but I don't know how much is like really in like a PT context. Again, because she has no insurance. With tennis, I know she's getting some movement in the upper body and the torso.
Yeah, but the natural movement should help. Like either you use it or lose it, right? That's what I tell people a lot. Because they want to stay up into a compression garment. My cosmetic clients want to wear a faja like forever because it makes them look good, because it's a compression garment, because it's a shapewear garment. And I say, like, if you don't use your muscles, you'll lose your flexibility and your ability to move and your strength and your core strength, which is why after Brazilian butt lift, like a lot of doctors won't let them keep the compression garment on over 2 months because they need that core to strengthen again. They need them to stand up and use their spine and all those muscles. So yeah, thanks so much for asking the questions and listening to the presentation.
Okay, Kathleen, thank you so much for being with us this evening and your patience. We really appreciate you.
Thank you. Yeah, have a great night, everybody.